Hello everyone. So we'll talk about tuberculosis today, better known as TB. It's a nasty respiratory infection, quite common in the developing nations, as we'll see later. So as usual, these are the objectives. We'll talk about the epidemiology, which is how it's spread among the population, the cause, the pathogenesis, some of the signs and symptoms, the investigations that we'll conduct to find out if we have TB, the criteria, the clinical and the bacteriological criteria for the diagnosis, how to identify latent infection. I'll talk about what latent infection is versus active infection. We'll look at a brief overview on the treatment and the mechanism of action of some of the anti-TB drugs, mainly the two main ones, isoniazid and rifampicin. And we'll also talk about types of TB resistance and some of the consequences of a post-TB infection. So epidemiology, 30% of the world has latent TB. Latent TB is basically when you have the disease, but you don't show the signs and symptoms. That means the bacteria is dormant, it's sleeping in your body, but you still have it. And out of those 30%, 10% will trigger reactivation, which means now actually manifesting the disease, showing the signs and symptoms of TB. Now, translated into numbers, 10 million people have active infection. Active infection means TB showing the signs and symptoms. And out of those 10 million, we have 1 million deaths per year. So we can see TB is, it can be fatal if not managed early. So the cause of TB, it's a bacteriological disease, and the bacteria involved is Mycobacterium tuberculosis. It's a slow-growing bacteria with a lipid-rich wall. We'll see the significance of it when we're doing the diagnosis. Because of its slow-growing nature, culturing the bacteria takes quite a while, and because of the lipid-rich wall, we use specific stains to observe the bacteria under a microscope. So usually it's acid-fast bacilli because of the lipid-rich cell wall. So we use the Zn staining, as we'll see later. So there are so many types of mycobacterium, but I've just these are the 5 common ones. The M. tuberculosis, the one that causes TB. There's Mycobacterium leprae, which causes leprosy. We have Mycobacterium bovis, which affects cattle. And of note is we use the antigen from Mycobacterium bovis to create the BCG vaccine that's given to infants at birth. There's Mycobacterium avium, which affects birds, and there's Mycobacterium abscessus. As I said, there are so many other mycobacteria, but these are the common ones. Now, the thing about Mycobacterium tuberculosis, it's mostly a human pathogen. This means you don't really find it outside the body, the human body. In the environment, in the soil, you don't find it there. There's some cases of it found in some macaque monkeys and some elephants, but it's rare. It's usually only affects humans. Now there's this other type of bacteria, it's a non-tubercular mycobacterium. These ones are now found in the environment, mainly in the soil, and it's TB-like in its presentation. It causes some pulmonary damage, but it mainly affects people with already damaged lungs or a weakened immune system. Now, a bit of the pathogenesis. So it's a droplet infection. That's how it's transmitted. So when someone coughs, someone with active TB coughs, the droplets contain the mycobacteria and then they enter your body. So usually they enter your macrophages. Macrophages are white cells that are supposed to eat up foreign organisms. But the thing about TB is when it enters the macrophages, it disables those systems. So the macrophage cannot digest that TB because it disables the phagosomal pathways. So now we have macrophages with the mycobacterium inside it, and it can kill that mycobacteria. So the infected macrophage usually spreads throughout the body, especially using the lymphatic system. That's why one of the most common extrapulmonary sites of TB is the cervical lymph nodes because of this lymphatic spread. Now, when you get exposed to the bacteria, there are 3 things that can happen to you. One, if your immune system is strong enough, those infected macrophages can be immediately destroyed by your other stronger white cells, or If the TB decides to stay low, lies dormant and sleepy, that infected macrophages can be surrounded by other white cells but not killed. It's just like it's caged and held in for years. That's latent infection. The latent infection has the possibility to be triggered into an active infection once the immune system of your body weakens. So that prison of white cells surrounding the infected macrophages, once the white cells weaken for some reason and the prison weakens, the bacteria can escape. And then the third one is active infection. It's when you get exposed to the bacteria, your immune system is weak from the beginning. So it doesn't have that ability to cage that bacteria down. So the bacteria just replicates and spreads all over. So usually it's the active infection is called the primary TB. We'll look at it later. So here, if immune system is strong, your infected macrophages are destroyed. If it remains dormant, it's called latent TB with the possibility of reactivation later on. So when the immune system is weak, the third one, and there is active replication and the TB spread throughout the body, that's now called active TB and primary TB because it's the first instance of exposure, and from the first instance of exposure, you got the active TB because your immune system is weak. So this one is usually seen in children and immunosuppressed people. So primary TB is when you first got exposed to the bacteria. Your immune system never stopped the bacteria in the first place, and it started dividing and causing disease. That's primary. Secondary is when you first got exposed to the TB. Your immune system caged the infection, and later, when for some reason the immune system got weaker, the bacteria broke out of the cage and started spreading. So that's secondary TB. So the thing about TB, it mainly affects excuse me, the epicenter of the lungs, the top of the lungs, and it causes cavitation, as we'll see a few chest X-ray images of what TB does to the lungs. Now, clinical manifestation. The most important clinical manifestation of TB is the systemic one. So, the telltale signs of systemic manifestation of TB is weight loss, usually more than 10%, and it's unintentional, night sweats, fever, and malaise. Now, local symptoms depend on where the TB is. TB is one of those diseases that can affect every single part of the body. So we are more familiar with the one that affects the lungs, the pulmonary TB. So the symptoms of pulmonary TB are as follows. We have persistent cough of more than 2 weeks. We have hemoptysis, which means you are coughing out blood. There is blood in your sputum. We have difficulty in breathing. And then we have clinical signs of pleural effusion. TB is an inflammatory condition, so it causes the pleura to excrete an exudative fluid. So pleural effusion just means that there is fluid in your pleural cavity. The pleural cavity is supposed to have a negative air pressure. It's supposed to be free of air or anything. But because of TB and the inflammatory processes, we have an exudative fluid filling up the spaces of the pleural cavity. It affects the expansion of the lungs. So the clinical signs of a pleural effusion is the reduced expansion on that side. It's dullness on percussion, and on auscultation, there are reduced breath sounds on that side. Now, extrapulmonary, as I said, it can affect any part of the body, but these are the main sites that are affected. We have the meninges, so we have TB meningitis. It will present as a stiff neck and focal neurological deficit, which just means there is a problem in some part of the brain, and it can present as paralysis, can present as vision impairment, can present as auditory impairment, depending on the part of the brain that's affected. We have Poch disease, which means the TB is affecting the spine, the vertebrae. Usually, thoracic vertebrae is the most common one affected, thoracic and lumbar. So we have back pain, paralysis, urinary and bowel incontinence. And if it affects the abdomen, you'll have ascites, which again is an exudative ascites because it's an inflammatory process. The investigations we do for TB, again, you must do full blood count for any sick patient. So we'll have a leukocytosis, which means increased white blood cell count because it's an infection. But unlike other bacteria, where we have neutrophilia, in TB we'll have a lymphocytosis. The same if you do if in case you're suspecting TB meningitis, you'll do a CSF, you do a lumbar puncture, and the CSF cell count will have a lymphocytosis and have high protein as opposed to a normal bacteriological meningitis where you have neutrophilia. The main one is sputum microscopy and culture. So as I said earlier, for sputum microscopy, you'll use the ZN stain, the Ziel-Nelson stain, and because of the acid-fast bacilli, it will light up if you use the ZN stain. Culture, as I said earlier, it takes 4 weeks because it's a slow-growing bacteria. So we use the Lowenstein-Jameson medium. It takes about 4 weeks to culture. So because of the lengthy time taken to culture and the need for quick treatment of TB, we usually have another method called gene expert, which is rapid and it has similar specificity and sensitivity as culture. So it usually takes within 2 hours, and you can confirm that whether the patient has TB or not, so you can start treatment. We can also do a chest X-ray, which, as I said earlier, it will show apical cavitation and hilar lymphadenopathy. Now, these are the chest X-ray findings of pulmonary TB. Part A is showing, as you can see at the apex of the lungs, there is a dark spot surrounded by white tissue. So this is just apical cavitation. This means a hole in the lung, usually in the top of the lung, the apex of the lung. And the second image shows consolidation in the apices of the lungs. There's also a bit of hilar lymphadenopathy around the heart area. Now, another form of TB is miliary TB. Miliary TB, the word miliary comes from millet-like. On chest X-ray, you'll see millet-like seeds all over the lungs. So these are lesions of TB spread all over the lungs. These ones follow the pathway of the blood vessels. This one is usually when the mycobacterium enters the blood vessels. As we know, blood vessels supply the whole of the lung, so they spread out throughout the whole of the lung. And miliary TB can also go into, again, it goes into blood vessels, it can go into the lungs, and it can go into the rest of the body. This one is mainly seen in primary TB. As I said earlier, primary TB is the one that you have the first exposure to the TB. Your immune system is weak from the beginning, so there is usually no inhibition to the spread of the bacteria, so it spreads everywhere. And usually, it presents as miliary TB. So as I said, millet-like seeds everywhere in the lungs. So diagnosis, we have the clinical diagnosis and we have the bacteriological diagnosis. Usually, we follow the clinical one because we need to start treatment as early as possible. So any two of the following, these are systemic symptoms: fever, night sweats, weight loss, cough, and lethargy. Cough usually more than 2 weeks, plus any two of these. Abnormal chest X-ray findings, so the apical cavitation and the hilar lymphadenopathy. Abnormal respiratory signs, which are signs of pleural effusion. Positive contact, if you have history of contact someone with non-TB or having been treated with TB in the past, it's one of the criteria. And a positive Mantoux test. Mantoux test is, we'll see later, is when you inject the antigen of the mycobacterium into your skin. And if you've been exposed before, there'll be the immune memory. So you'll have a quick reaction of a heal and flare. So you'll have basically swelling. We'll have swelling and redness on your skin. So that's one of the signs that will make the clinical diagnosis of TB. Bacteriological diagnosis is simple. You just have to identify the bacteria and see it. So microscopy or culture. So latent infection, again, is you're not showing the signs and symptoms of TB, but you have it in your body, it's caged. So Mantoux test, as I said, as I described it earlier, and the interferon gamma release assays. Now the difference between these two is in Mantoux test, if you have received the BCG vaccine, it will still be positive because you technically you have the TB antigen. But for interferon gamma release assays, it's specific only for a TB infection, not BCG vaccine, because gamma, as we know, interferon gamma is released by T cells and macrophages, so they are only triggered by an actual TB infection and not the BCG vaccine. So treatment, we have the first line and the second line. First line treatment is pyrazinamide, rifampicin, isoniazid, and ethambutol, and also streptomycin. Second line is fluoroquinolones, kanamycin, capreomycin, and amikacin. So the regimen that we use in Kenya, it's for the first 2 months we use 4 drugs. The reason we use so many drugs for TB is because of the advent of TB resistance. So in case by any chance the bacteria is resistant to one drug, we hit it with four. So there's no chance for it to survive. The first 2 months we use isoniazid, rifampicin, pyrazinamide, and ethambutol. And then the second 4 months we use 2 drugs, isoniazid and rifampicin. So it's a 6-month regimen. However, in case of TB meningitis and TB that's affecting the bone, we extend it to 12 months. So I'll talk about the mechanism of action of the two main drugs, the isoniazid and rifampicin. So isoniazid prevents mycolic acid synthesis, which forms the cell wall. Mycolic acid is used to form the cell wall of the bacteria. So without the cell wall, it's exposed and it dies. So it's bactericidal. Rifampicin, however, it inhibits RNA polymerase, and RNA polymerase is used in replication of the TB. So it does not actually kill the TB, but it stops replication, so it's a bacteriostatic disease. So it affects more of the slow-growing bacteria, while isoniazid rapidly kills the existing bacteria. So types of TB resistance, we have monoresistance. As the name suggests, the TB is resistant to one of the first-line drugs. Polydrug resistant means it's resistant to more than one drug, and usually either rifampicin or isoniazid, but not both. Multi-drug resistant, the TB is resistant to both rifampicin and isoniazid. So you have to go for the second-line drugs. So extended drug resistance, this is when the TB is resistant to both rifampicin, isoniazid, fluoroquinolone, which forms part of the second line, and one of the 3 injectables. One of the 3 injectables, as you remember from the second line, was amikacin, kanamycin, and capreomycin. So in extended drug resistance, TB is resistant to rifampicin, isoniazid, fluoroquinolone, and either kanamycin, amikacin, or capreomycin. The mortality is really high for extended drug resistant TB. And then there's total drug resistance, which means that TB is resistant to every drug that you throw at it. Now the sequelae of TB, which means the complications you get after you've healed from the TB. So because it's a very highly inflammatory condition, there's a lot of inflammatory damage to your lungs. So we end up with pulmonary fibrosis. And as you know, when there's fibrosis, there's loss of function and this shrinkage of the actual lung. It's not drugs, it's lung. So with pulmonary fibrosis, your capacity to breathe reduces. So it kind of leads to a type 2 respiratory failure because your the actual lung that does the breathing, the respiration, the volume of that lung goes down. Most of it is fibrous tissue. It can also cause hemoptysis. Remember the cavities that TB formed. Now the TB has died, but the cavities still remain. So there is a likelihood of that cavity being infected by other organisms, usually fungi, mycetoma. So this one can present as hemoptysis. And it can also cause bronchiectasis. Bronchiectasis is which means when your bronchioles are, the walls of the bronchioles are damaged by inflammation, they become weak, and usually they dilate because of the weakness. So as they dilate, it gets filled with mucus and sputum, and it's one of the chronic obstructive pulmonary diseases, because as air comes in, when you breathe in, air will come in, but then because of the dilated and the damaged bronchioles, not all of the air will come out again. So there'll be kind of an lung infection. The bronchioles are filled with sputum. The bronchioles are filled with mucus. There'll be a hypoxic condition. There'll be a COPD-like condition. There'll be resistance, and finally, it can actually lead to lung collapse. So these are some of the complications of TB after you've healed from the infection. Thank you.